Welcome to the Becker's 12th annual meeting virtual event and featured session, Virtual Care is Transformational Care. I'm Molly Gamble with Becker's Healthcare. Thank you so much for joining us today for what will surely be an engaging discussion about how virtual care is transforming care for today and the future. I want to first thank Bioformis for sponsoring today's session. Bioformis is a global health technology company focused on improving the delivery of healthcare in the home. They partner with health systems like UCI Health, Mayo Clinic, Brigham and Women's, and others to provide FDA-cleared, clinically validated software and advanced tools for their clinicians to deliver personalized patient care. Their AI-powered platform, Care at Home, enables remote care across a range of medical conditions and across the continuum, including acute, post-acute, and chronic care. I will now walk us through some quick housekeeping details and introduce today's speakers. First, you can submit any questions you have throughout today's session in the Q&A box you see on your dashboard. Today's session is being recorded and will be made available after the event. You can use the same link you used to log into today's session to access that recording. And finally, if at any time you don't see slides moving or you have trouble with audio, try refreshing your browser. You can also submit any technical questions into that Q&A box. We are here to help. With that, I am pleased to introduce the terrific speakers joining us today, Dr. Tahir Huq, Dr. Jared Connolly, and Susanna Rusted. Dr. Huq, can I turn to you to introduce yourself first, then we'll hear from your co-panelists?
Sure. Good morning, everyone. My name is Tahir Huq. I'm an internal medicine physician and I practice at Brigham and Women's Hospital in Boston. Brigham and Women's is a quaternary care facility with a focus on oncology and cardiology patients. Like many other academic medical centers, we pride ourselves on innovative care, and I'll highlight one such program in our discussion today. I joined Brigham back in 2019, initially in the hospital medicine unit, and then transitioned to the home hospital program. I hold a secondary appointment in the Division of Global Health Equity, serve as an instructor in medicine at Harvard Medical School, and am an associate faculty member at Ariadne Labs. My clinical and research work focuses on improving clinical care through innovative care delivery and health equity initiatives. It's a pleasure to be here and I look forward to the discussion today.
Thank you so much, Tahir. And Dr. Connolly, can we turn to you next?
Yeah, absolutely. Jared Connolly, I'm an emergency physician at Mass General Hospital and work also as the Associate Director of the Healthcare Transformation Lab there at Mass General. We do a lot of work in virtual care and thinking through new ways of delivering healthcare, often through the lens of both design thinking and digital health. I also am involved with the Hospital at Home program. I'm on a leadership team there at Mass General that's been around for about 5 years now, and so it's been a nice opportunity to rethink how we deliver hospital level care in the home.
Thanks for being here, Jared. And then Susanna.
Good day, everyone. My name is Susanna Rusted, and I'm the Chief Procurement Officer leading end-to-end supply chain. So supply and demand matching and linking is our specialty. And I'm the Executive Director of Virtual Care at UCI Health. We're one of the leaders for expanding into advanced care at home outside of our traditional 4 walls. UCI Health is the clinical enterprise of the University of California, Irvine. So we're an academic medical center with tertiary quaternary care, ambulatory specialty medical, behavioral health, rehabilitation services, and Orange County is home to about 4 million residents. And we're the only NCI designated comprehensive cancer center. We have the busiest trauma center in Southern California and the second busiest in California. So all to say that we're bustling. It's a bustling city, and what we're working on, our vision is to transform healthcare by building an expanded, safer ecosystem that has quality safety built in and efficient manner. We believe this is all the foundation for existing and future value-based care. So we believe we are capable of redefining healthcare, and that creating healthcare without boundaries is something to achieve as a community benefit.
Thank you so much, Susanna. Well, we are going to be talking about virtual care today and in the future over the next several minutes. But first, let's take a step back. I would love to hear about when your organization started to consider starting a virtual care program. What challenge was it addressing? New programs in hospitals start to solve for existing problems or challenges. So if we could take a step back and understand the context and the circumstances your programs were born from, I would love to begin there. Susanna, can I turn to you first to share your thoughts on this thought?
Sure. As far as embarking on this program, virtual remote care, it was truly to address capacity and access issues. So we wanted to expand care supply, as well as meeting the patient demand that really in today's consumer age requires an array of integrated digital care supply avenues. So this is what our care is predicated on in terms of building out the platform, the technology. We also have a new medical center complex coming online in 3 phases later this year, next fall, as well as the hospital in 2025. And most of the projections, market analysis shows a gap in what's being built versus what the demand will be. So if you think about, we're not building hospitals fast enough. As soon as that hospital is ready, within probably the first quarter, it'll be filled to capacity.
So really for capacity constraints, the infrastructure can't keep up with the demand. Let's see, Jared, was it different for you in Boston? Were you seeing some different circumstances that helped your organization launch its program?
Yeah, I mean, certainly I think it is a lot about capacity, and I think COVID-19 certainly accelerated that. But I think probably like Susanna, right? Capacity is just such a major issue, right? You have patients that want tertiary and quaternary care and aren't able to get that, right? Whether that's because they're waiting in the emergency department for 24 hours to get upstairs, or because they're trying to come from another outside hospital in the New England area and can't access that care. And so capacity has been a driving force for us as we've thought through this, and also just that patients want to access care as conveniently as possible, right? And so the reality is, I think those 2 forces are really pushing us to rethink how we deliver our care, and maybe even disrupt the thinking that the provision of care and the site of care are always tied as closely as they have been traditionally, right? And to think through ways that we can deliver the same care, but do it more in a convenient manner for our patients, particularly those that, transportation could be an issue, or also those that might live a lot further outside of the greater Boston area, but still want to access Mass General care.
Here, what would you add to this so far?
I'd like to echo what Jared and Susanna have already said. I think, our virtual care program was created obviously to mitigate capacity, but also to let people age in place, to deliver care where they are, like Jared mentioned. I think the unique part about Brigham and Women's, which is also, I think, the same for Mass General, is that unlike many of the other acute care at home programs, our home hospital program started a few years before the pandemic. And the goal solely for that was to deliver a better quality of care, specifically at home. And, with the COVID pandemic, our care at home program has scaled and it's grown to encompass more disease states and different conditions across all of our hospitals. So very proud to see that growth.
I'm going to turn back to you for the next question. I would love some input on, and that's just about the unknown unknowns that surround virtual care. Often the questions that really uncover the need to start a remote patient monitoring program or hospital at home program, those questions haven't been asked. What are some of the questions that you feel would reveal to leadership gaps in a remote patient monitoring program or hospital at home program could fill? As you're connected with colleagues today, what's an example of a high priority need or gap that can really, really benefit from a virtual care program?
Thank you, Molly. So as far as revealing questions, I think as we're looking at today's pressing healthcare issues, what leadership could seek to ask is probably regarding strategic positioning and financial sustainability. These are 2 very important areas. How are we evolving as an enterprise so that our service line strategies are relevant, stay relevant, and compete as new healthcare ecosystems are emerging and there's new entrants and competitors in that sense. Financial sustainability, we're building a new hospital. We know that building one new room capacity is just a tremendous amount of money. I believe it's $2 or $3 million, depending on where you are. And in California, it's $4 million. So how do we reduce operating costs and have speed to market to be able to have increased access to care? Other questions might be health disparities, the health equity equation. Are we addressing social determinants of health? How is that being built into today's mounting healthcare issues? There's certainly the digital and the information platform aspects, the provider clinician enterprise, and how to interweave those elements into the questions of like, how does RPM and hospital at home programs really expand our tool set? So an example for us at UCI Health of a high priority need is reducing recidivism. So if we're able to reduce readmissions, everyone benefits. The patient is receiving better care and better outcomes. The hospital bandwidth is increased. So having a remote monitoring program that engages the patients daily. So they have several check-ins, they have symptom checkers, they have these questionnaires and the ongoing biovitals that are collected. And you add that to the 24/7 around the clock monitoring command center. And there we have many stories of patients who they were about to represent at the hospital, but because of the treatment and the coaching and the interventions that were available through the 24/7 monitoring, they did not go back to the hospital. So they were seriously contemplating. For example, we had a COVID patient that had been discharged and he was very nervous. He kept texting and calling our 24/7 monitoring system, and they were able to assuage his concerns. He had concerns about his symptoms. He had questions about his medications. He was just very nervous, and he thought at one point, I better just go back to the hospital. But so we all have figured out through COVID and pandemic that COVID is, in many instances, patients require that counseling. They want to know how this impacts their family. They're at home, and how do they protect their family members? So there's a lot of instances where that health coach can really provide them all the information they need without representing in our hospital.
Thank you, Susanna. So you uncovered a lot there. Obviously, the financial stakes of building new infrastructure. You mentioned it costs $4 million for a room in California. Is that right?
Correct.
Okay, so that brick and mortar really slows hospitals down. So this helps create agility, helps your organizations remain nimble, and like you said, standing up against those new entrants in the industry. And then also you mentioned health equity, more access points for people to ensure they have access to high quality healthcare. And then I love the example about the COVID patient who felt anxiety and nervousness, would have otherwise presented to the ED, but thanks to the RPM technology did not need to do so.
Thank you for articulating that so well.
Dr. Huck, let me turn to you because I would love to check in about the hospital at home program. We've seen so much interest from hospitals since the beginning of the pandemic. You have over 200 hospitals that have received the CMS waiver for hospital care at home. There's clearly interest here. There's clearly enthusiasm. However, there are still many hospitals that haven't applied and that don't have the maturity like Brigham and Women's does. This would clearly be considered a more mature hospital at home program. For those in the audience today who are earlier on in their journey, what are the top 3 benefits or improved outcomes you can point to for the Brigham and Women's program and boast about since it began?
So I think Susanna touched on this earlier, but readmissions is one huge factor. I'm fortunate enough to be at a program which had the first randomized control trial which studied or looked at home hospital patients kind of compared to traditional inpatients. So in terms of just numbers, at Brigham and Women's Home Hospital program, we showed a 38% reduction in cost of care and a 70% reduction in readmissions compared to traditional inpatients, which is significant. It also showed that patients who are treated at home had fewer diagnostic tests ordered, as well as fewer specialty consults ordered. So obviously decreased utilization, and patients who are at home spent less time kind of in bed or sedentary compared to their brick and mortar kind of counterparts. I think I'd also like to highlight something that's less discussed, which is patient satisfaction. Being able to deliver care to a patient in their home has a profound impact on a patient's perception of care as well as their disease. And it, improves the patient and provider relationship. When I first started in this role about 2.5 years ago, I had the opportunity to care for a patient who was about 48 years old. She had congestive heart failure. In the past year, I think she had 5 or 6 recurrent admissions to the hospital for the same exact symptoms. It was shortness of breath and leg swelling. So this time, given that she was clinically stable and a great candidate for receiving care at home, she was transferred to our program instead of being admitted. Similar to the hospital, we were able to give her intravenous medication to remove the excess fluid on her body. But at the same time, we were able to set her up with a meal service that provided appropriate food for her congestive heart failure. What we quickly noticed was looking through her pantry and fridge, obviously with her permission, was that she was eating foods with high salt content and not able to kind of restrict her fluids appropriately. We work with a community partner that's able to provide long-term food for patients who are unable to kind of cook for themselves or who have limited resources. And just based off of that simple change, we were able to kind of reduce her further presentations to the hospital. What's interesting is, when she was previously admitted to the hospital, despite being kind of told what types of food to eat after being discharged, it was very difficult to follow up with her and make sure that she was kind of enacting that change, or she was even able to implement that change. And, just from this simple example, I strongly believe that, care at home programs can facilitate such change because of their high touch and kind of personal factors.
You outlined 3 great benefits to the program, including patient satisfaction, more visibility into the patient's home, their living conditions, that their life, day-to-day life. That's a terrific example and story. Thank you so much, Dr. Huck, for sharing that. Jared, let's hear from you about threats. I would love to learn from you what you see as the biggest threats in year 1 of a virtual care program. What are some of the ways you've seen organizations address those?
Yeah, absolutely. There's lots of threats, unfortunately. Anytime we try and do what's right, obviously, there's lots of barriers. I think, we can break it down a few different ways. I think for one, it's just simply new clinical workflows, right? Which really challenges the workforce to rethink how we're delivering care, right? We've gone from models where we're very used to, certain types of patients presenting to certain physical locations to now where we're having patients present to different locales or even just staying in their homes, and trying to give that care really can mess with the clinical workflows. And so I see that as actually a significant threat just to the status quo of how we're delivering healthcare. That can affect, IT work streams. It can affect clinical work streams in many different ways. And certainly I think it gets also at culture, right? Which I think is also another significant threat to virtual care, is that the culture of delivering care traditionally, especially to kind of acute care or peri-acute care, has been all about the in-person phenomenon, right? We feel better when the doctor's putting his hand on us, right? It's a more healing effect. And so I think the culture takes time to really help us understand, again, in the end, what are we searching for, right? We're searching for the ability to deliver care that is highest quality, lowest cost, best patient and clinician experience, right? And that has been disrupted, right, in terms of how we can find that trifecta with the use of technology. But it really can be jarring to the clinician culture, and I think also to the patient culture, right? That they think that they need to be in a certain place to get the kind of care that they need. Payment is always, of course, another threat. It's the looming threat always for virtual care. As we look to Congress, as we look to the legislatures in our state to think through, how do we make sense of all this? And I think the threat is because of the opportunity to essentially game the system, right? I think everyone's hopefully well aligned and trying to deliver the best care. But in the end, right, you could see the ability to overuse virtual care in ways that, can generate revenue, but not necessarily generate significant value. And so I think it really behooves all of us in this space to really develop, important understanding through research, whether that's operational or more traditional, and understand where is it that we should be delivering virtual care and where should we not. And unfortunately, that takes time. And in the meantime, we're trying to deliver this care, right? And so that creates a threat as we think through, how do we do this right without, overstepping the bounds of what should be good virtual care.
Workflows, culture, payment. When it comes to the culture point, Jared, how have you seen organizations progress or mature throughout that, where they go from thinking care needs to be delivered with hands on the patient to being comfortable and embracing virtual care for the goals that you outlined?
Yeah, it takes time. Honestly, our experience at Mass General, it just takes time, right? It's a comfort level. It's having cases where you can experience it. It's learning from the times when maybe virtual care didn't go as planned. And rather than giving up on it altogether, right? Thinking through, okay, we've learned from this, perhaps less than ideal experience. But honestly, at Mass General, right, we have a variety of programs. We have a similar program to Brigham around hospital at home, or home hospital as we refer to it. We have a virtual observation unit that's run by some of my emergency medicine colleagues, where we're delivering observation level care virtually in the home, and several others. But all of these programs, it takes time. I've seen a lot of my colleagues, and including myself in some of these that I work in, right, getting used to being able to not touch the patient, not put the stethoscope on the patient. You really need to understand when is it okay to do that and when is it not. And it takes time. And, again, it's going to take research to show what's safe and what's not safe. But this is a journey.
Thank you so much. It takes time. Suzanne, I'm going to turn to you to talk about metrics, measurements. How can organizations accurately measure the success of RPM or hospital at home programs? What are those must-have, must-monitor, must-watch metrics from your perspective, and what does success look like with them?
Sorry, here we go. So as far as metrics go, this is very important for quality and safety, and we have early outcomes data. So early outcomes data shows no sentinel events. This is important. No mortality or no preventable mortality. There's the infections. We certainly want to follow and see if there's any issues there or challenges, and at the improvements. For us at UCI Health, significantly as far as the readmissions rate, we typically experience about 13%. With our remote patient monitoring program, we're at about 6% and holding. And in these cases, we also want to follow a patient's sort of post-care, and if they've been able to be seen with follow-ups within 7 days of their discharge. Patient satisfaction, this is something we're monitoring as well, post their discharge and during their RPM program. We have a series of survey questions that can really indicate how they are enjoying the program and the connectivity and the extra resources at their fingertips. One of the examples of what does success look like, I think really we can talk about a case where we have a patient that actually did end up being rehospitalized. However, it really indicates a level of transparency and connectivity to that patient beyond our four walls that we've never had before. And in which case, this patient was wearing their Bioformis Averion for very consistently participating in the program. The healthcare nurse, the RN at the command center, noticed and got the alert. The biofitals alert index indicated the trend of O2 was in the wrong direction and at 78. So they reached out to this patient and found out promptly that the patient was actually at the doctor's office, and their caretaker decided to turn off the oxygen to see if he would be fine without it, because he seemed like he was doing very well. So they were in the waiting room and they had no report of complaints or symptoms. So the caregiver was actually advised by biopharmacists at this 24/7 command center to put the patient back on to the oxygen and continue to use it as prescribed, and explained the importance for the patients to follow those doctor's orders. And so the caretaker was able to verbalize the understanding, and the mask was put back on. It was a few minutes later, when there was no improvement in the biovitals index, that the alert came from the AI platform. And so the healthcare navigator called back the patient to see what is the circumstance, because the index, the vitals, was not improving. And this is where they discovered that the oxygen tank was actually empty. They still denied feeling shortness of breath or any other symptoms. So the caregiver was advised by the clinician to notify the nurse at the doctor's office, and they were able to quickly assess that the tank was empty and provide them a full tank. The patient was then taken into the office for further evaluation. And this is where they disconnected from our program. And it turns out that the physician was a bit worried about the low heart rate. And it did seem as the patient was having trouble breathing at that point. And so after the examination by the physician sent the patient to the ER. But looking at, having a look back at this data, what's really interesting is that all along the way, through this program, we were collecting all these data points. And so it was very easy to see that the low heart rate and whatnot, the trend, the patient had, the physician had access to all the data that had been collected. And this is a very data-rich program. They probably would have been able to make a different judgment call. So even though in this instance, it wasn't necessarily a success, but I would classify it as such, because it really demonstrates the power of remote patient monitoring programs, virtual care, and the technology aspects that make it possible are really all converging, in a sense that if it becomes mainstream, then we'll be able to take healthcare to the next level.
Yeah, I think that story illustrates so many things. I mean, the importance of real-time communication. I think also the ability to see the greater story with that patient than the limited views you might have had otherwise. So thank you so much for sharing those metrics and those measurements to keep a close eye on. Dr. Khan, let's turn to you. I mean, I don't want to talk about all these programs like they're all the same. I think each, as illustrated by that story, there's different technologies, different tools that can really bring unique advantages for clinicians and patients and their families. What are some of the most interesting capabilities or tech that you've seen being offered to support the remote management of patients?
Yeah, great question. I think, in the end, what we're learning is that in the end, maybe we don't have it all right in the hospital, right? So we specifically look at hospital at home or home hospital, right? What it's causing us to reflect on is, how should we really be monitoring patients, right, when they're having an acute illness? And what you see from the literature is essentially that, we have some evidence around who should be monitored continuously, who should be monitored, somewhat intermittently. Should we do vitals Q4 hour or every 4 hours or every 8 hours, or is every 12 hours okay? Right. What we've learned is we've looked back at the hospital to kind of advise us in the hospital at home settings is that, we probably don't have the evidence sufficient to know exactly what, populations of patients should receive. So I think that's important to recognize. As we think about, again, what should be the type of monitoring we need. And then, of course, what is the tech to do that? I think there's a lot of exciting tech coming out and has been advancing over the last kind of 5 to 10 years, certainly around anything that it allows for, wearable assessment of vitals. So whether that's a patch, whether that's an armband, whether that's even potentially on the wrist or the finger, right? All of those have different strengths and weaknesses. And I think we're seeing a lot of great advancement in the technologies that allow for accurate measurement of vitals. I think we're having challenges as well in that space with certain technologies, which many of them are based off PPG or photoplasmography, where motion that wasn't often a problem in the hospital can be a significant problem when someone's in the home, because they're, as Tahir said earlier, right, these patients are less sedentary, which is actually probably very helpful for healing, but that can then affect our ability to get accurate measurements. And so I think there's a lot of great work happening there. There's a lot of opportunity to think about kind of ambient monitoring of vitals. So whether that might be through radar or LiDAR or other ways to think through, something that's not wearable, that just sits and monitors us as we sit a little bit more stationary. Those technologies work better also without motion. But it's really, I think, a fun journey for us as clinicians to think through, what is the type of monitoring my patient needs, right? Not all heart failure is the same, right? Not all COPD exacerbations are the same, and really thinking through better understanding of who needs what. We need to do a lot more development in that space. And fortunately, again, industry is helping us a lot on new technologies, as well as academia, thinking through, where should we place it on the body? What's the technology method that we should be using to assess those vitals? And then really, how to understand how that data gets seamlessly portrayed to the clinician so that they can make the best decisions, right? Because obviously one of the biggest problems here is just an overload of data. And so knowing, again, how do you present that data, that we now have a lot more data on perhaps a patient's physiology, how do you now present that in a way that makes for the best decision making? And I think we're seeing a lot of great initial work in that space, but it's an exciting time.
Great overview. And I think you teed up my next question for Dr. Huck quite well with your opening remarks about, we have some evidence of who should be monitored remotely, but that still it comes down to individual decision-making from the care team. Dr. Huck, what conditions or patient profiles have you seen the most success with in terms of using RPM to manage their health and their outcomes and their care journey?
Yeah, that's an interesting question. And I like to think of it mostly in two buckets. One is obviously the chronic conditions that we see. So bread and butter medical things like congestive heart failure, COPD, diabetes, hypertension, even cardiac arrhythmias like atrial fibrillation. The other bucket that's more prominent nowadays is the severe acute illness that kind of requires some transition of care or monitoring while you're transitioning of care. So for example, COVID. I'd like to focus on the first bucket because I think those patients are likely to have the most benefit of such a program. When you think about a patient that comes in with a new diagnosis of diabetes, let's say, we're able to, in the acute phase, control their blood sugar level, kind of stabilize them. And then when they're ready for discharge, we've now started them on at least one oral medication, and depending on how uncontrolled their diabetes is, possibly two injectables. So one long-acting insulin and one short-acting insulin. And, we do a brief bedside teaching and we send them on their way. When they get home, patients are oftentimes confused. I have to take this medication twice a day, plus I have to inject myself now 4 times a day, and I don't know which pen is used kind of at what time. So I think just the sheer amount of management that's required for certain chronic conditions, like the medication administration, the diet adherence, and kind of being mindful of potential complications that they might have, really shows the value of a RPM program and kind of managing these patients through synchronous and asynchronous touch points. The other patient population or group of patients, which Susanna touched on earlier, are kind of patients with limited resources, patients with limited English proficiency, and patients with limited healthcare literacy. These patients oftentimes are neglected, not intentionally, but only because their background is such that they're not able to kind of voice their concerns in a way that other patients might be able to do so. And because oftentimes these issues might go unaddressed for longer periods of time, it can lead to more complications. So what we've seen is that intervening early and intervening frequently with these type of patients helps them have a better disease trajectory or outcome trajectory than their counterparts that might not have access to such interventions. More and more, I think, as virtual care programs become mainstay, I think health equity is a is an important part or an important consideration to take in making sure that your program encompasses different factors that would address that?
Well, let's move on to my closing question, which I think is probably going to be the most tricky question, given that I think the past couple of years have made us all a bit more hesitant to make any type of projection or forecast. But if I came to you and asked over the next 5 years where you see virtual care evolving toward, I would love to hear your thoughts, especially about what clinical areas have the most opportunities in this space. And then also, what do you see as stumbling blocks to continued momentum? What could potentially get in your way? Susanna, can I turn to you first?
Sure, thank you. So the healthcare landscape is evolving, we all know this, and we've talked a bit about where the existing model, we'll call it the old model, is provider-centric. These are where the patients, we expect them to come to care, physical sites of care, and the shift is really to consumer-centric. We've talked about the convenience factor, but where all patients are trying to proactively manage their own health, and they want access to these services, whether, and they want it on demand, so when they need it. The evolution in redefining healthcare and building towards the healthier, more sustainable healthcare ecosystem is here. So how do we navigate this new era? Not just to survive, but we want to progress and arrive at better care. So as far as scaling and making virtual care mainstay, the new norm, we need to look to building the next generation care teams, increasing assets in the expanded care setting, and how do we integrate digital solutions, offer seamless experiences. This is all part of this patient-centric care model. So acknowledging that convenience and continuity is key. So how do we implement a care to you emerging model? At UCI Health, we've implemented a ED room alternative on wheels, like an urgent care on wheels. So we take that to the patient's home. A care to you can happen in many ways. Care anywhere, this is the virtual care aspect, that paradigm. It's all part of an ecosphere of solutions for patients. Patients are looking for help to manage their complex health. So what areas are most impactful or maybe easier to implement remote patient monitoring, virtual care, chronic conditions? This is where lifestyle, diet, exercise all come into the equation. So it's holistic care versus episodic. With the current fee-for-service episodic care patients that we see, we aren't really necessarily providing all the support they need in their context. So technology, rethinking healthcare can really change that. And we see the keys to success as really having a shared vision amongst our key stakeholders. So this is something we're working on as we're scaling. We're going from sort of project basis, and we have senior health, chronic conditions. We have our FQHCs working on access and health equity. We have our RPM program. We have also ventured into hospital at home. This is something we've not been able to do yet in California, but we did receive our federal waiver over a year ago. We've been building that out. And so how do we bring it all together under one big umbrella so that we're moving from a baseline of technical solutions and capabilities to a shared understanding of this longitudinal healthcare where consumer needs and expectations are headed. So what we need to do to continue the momentum and to not be stalled or have these stumbling blocks, these pitfalls, really creating that roadmap for a 3-year plan, a 5-year plan, that transformation plan, building out the infrastructure. This is not a side of the desk activity where people can just add it to their current plate. So building that infrastructure of functional and operational governance and the deployment of operational support, monitoring real-time performance for quality and safety, to track all of those things, just to name a few. So there's a call to action, and I think we've all been really immersed in that, but really getting to broaden that, to scale it, we really need to look at it an emerging model that's different than the old model.
A terrific overview of how you see things playing out over the next several years at UCI Health. Thank you so much, Susanna. Let me see, Jared, can I turn to you for your thoughts on this question? Where you see virtual care evolving, clinical areas with the most opportunity, and then stumbling blocks or roadblocks that could potentially get in your way?
Yeah, I think just building off what Susanna said, there's really just so many opportunities. There's so much low-hanging fruit in terms of how to redesign care and having that virtual lens on thing. I think, we think about it in terms of kind of science, technology, and then a business model. Now, the biggest challenge, of course, is the business model. I'll kind of tailor that towards the end around things that are blocking these opportunities. But really it comes down to the home as a center of healing, right? We are moving towards a world that wants to have that, right? We know that there's some good evidence that people heal best at home, as long as, again, they're getting the care that they need to solve their pathology. And so what we're thinking about is in terms of our opportunities is how can we use the power of the brick and mortar hospital when it's needed, but see that as a part of the episode of acute care, right? So when the brick and mortar hospital's needed, the most expensive hotel in town, if you will, right? You use it, right? But that might not be for their full, whatever it is, 4 to 8 to 20 days of acute care, right? Of a hospital care, right? That you actually might just need it for the first 2 or 3 days. And then if it's safe, you would transition that care to the home, right? And you'd still be giving the same provision of care, but it would be in a new healing area, right? The home, which is where patients want to receive the most care that they can. I was involved in a pilot last year, which is, we published some of this in our surgical hospital at home in terms of opportunities. Surgical hospital at home is a really ripe opportunity, right? Not a lot of evidence yet to show where it's best applied, but we do have some initial case reports and other studies, both in the US and elsewhere. Mass General just published their experience with this. And I've been involved with these where, again, you're doing the surgery in the hospital because you need the OR, right? And you need the safety of that space. They go to the PACU, right? And that from the PACU, again, for the right patients, it might be safe for them to care for them instead of the most expensive hotel in town, the hospital, to maybe a hotel next door. That might be very nice, right? But you can, again, put on your monitoring you need, have quick access to them, have that virtual experience through a tablet. And we've had a pretty strong experience with that and are continue to build off that. So I think there's a lot of ripe opportunity in the post-surgical space. And I think beyond that, I'd say, we could talk a lot about these areas, but I think around equity, kind of as Tahir said earlier, right? There's a real opportunity to think through how can we use technology to make an equitable delivery of acute care that involves the hospital when needed and the home most often, right? And we recognize, of course, that the homes of the world are not equitable, right? It doesn't take long to just drive through any neighborhoods and realize that, right? But the hospital, you see more of that equity, right? You have a strong network connectivity, you have obviously all the tech you need. So we're trying to think through ways to make this as equitable as possible, which generally means you just bring in that tech to deliver the kind of care that you need, right? You don't rely necessarily on home networks, right? You provide that network, you provide the tech. And so I think there's a real opportunity to continue this work and make it as equitable as possible. And there's been even recent studies out of Sinai, with Al Su and others, Bruce Leff, a recent piece on the power of hospital at home in particular to deliver more equitable care. On the side of, what is blocking all of this, right? I mean, again, if we were to just scratch our system, but keep our knowledge, right, we'd be building a totally different way of delivering acute care. What are the blocks of that, right? Well, of course, some of it's culture, but really it's about the business model, right? We're tied to these very expensive hospitals, right? And we've invested in them significantly, right? Whether it's $1 million per bed or $5 million, depending on where you're at in the country, right? I've seen it as high as 5. I don't know, Susanna, maybe it's just 4. I think California is definitely the highest, having lived there. But, that's our major roadblock, right? And so we need to think through ways of perhaps, not building new hospitals as Australia has done, right? They've actually moved towards virtual hospitals and a hospital home model. Or, could we even think about repurposing parts of hospitals that we don't need anymore, right? Could it be a new hotel? Could it be, some sort of other business space? Because again, we now have the home where we could deliver that same kind of care. So I think we need to be very thoughtful, have safety as the paramount, building block, if you will, but really rethink our attachment to the brick and mortar hospital and the opportunities we have to rethink the home as a center of healing.
Dr. Huck, your co-panelist just shared a lot there. Let me turn to you for what you would add, challenge, anything you would revise. Let's hear from you.
No, I kind of echo what they both have to say. I think the 3 main areas where we'll probably see some growth is obviously the post-surgical patients, like Jared mentioned. The 2 kind of other places that I would like to highlight is specialty care in the home. So you'll see, we already kind of do some basic cardiology and endocrine cases, but you'll see more and more specialized care like oncology in the home. So being able to do home infusions or management of certain complications from oncology conditions, all in the comfort of the home. And then the last, and I think unaddressed population, which I always like to highlight, is geriatric patients. So we've seen a lot of care models pop up with SNF at home or rehab at home, and allowing elderly patients to kind of age in place. I think that's an important segment of the population, because allowing them to be in a familiar environment, reducing complications and optimizing their functional status will preserve kind of the health that they have in kind of their latter years. And I think that's a very important group to kind of consider. In terms of hurdles, I don't think I'll highlight anything new. I think the one thing is beyond reimbursement, I think sustainable and integrated solutions across the care continuum is key. When we as providers get a patient that has their primary care doctor at Brigham, their cardiologist at Brigham, and now they're coming into the hospital and being admitted to at Brigham and Women's, it's very easy because I can quickly access those records. The patient knows everything that's kind of gone on with them. All of their medications are in one place, and we reduce kind of that utilization of resources. And I think the same thing will be important in the virtual care space, but not just for the provider, but also for the patient. If a patient has to go through, let's say, an acute care at home program that's separated or fragmented from its post-acute program and then its chronic care program, that becomes extremely challenging, because now you're having to learn 3 different systems. You're having to interact with 3 different teams that are kind of managing your care, maybe simultaneously at certain times, but also differently. So I think being thoughtful and mindful of the solutions that we create, because our end user is the patient at the end of the day.
Such a great point. Thank you so much. That is all the time we have for today. So I want to thank our terrific panelists, Susanna, Dr. Huck, Dr. Conley, for your time, your thoughtfulness, all of your valuable insights today. I also want to thank Bioformis for sponsoring today's featured session. And to our attendees who joined us, thank you for making time to be part of our 12th annual meeting virtual event. Make sure you check out all the other amazing sessions we have going on during this event. And please let us know if you have any questions, comments, or feedback. We would love to hear from you. Thank you again for joining us, and we look forward to seeing you at future Becker's events.